Thank you. It's a real pleasure to be invited to do this. And so, as was just mentioned, I run both a basic biology lab, but I also have field projects in Brazil. And how did I get these two things connected? So it's a long story, so I don't have time to go into that, but you can ask me afterwards. Basically, I do a lot of TB work, basic pathogenesis work on TB and gram-negative drug-resistant infections, diarrheal diseases. And it turns out many of these diseases that I work here in the lab are diseases of major global public health importance. And so many years ago when I used to work at CDC, before I became an academic person, I was sent to Brazil to work on diarrheal diseases. And then I quickly discovered that these diseases occur in little kids who live in these informal settlements, which now we refer to as slums. And so when I joined Cornell many years later as a faculty, I started working on diarrheal diseases in Brazil. And in the process of working in these projects in Brazil, I also discovered that many other infectious diseases that happen in these communities. And so it eventually evolved to a point where we realized that these issues had to be explicitly addressed and not just addressed in terms of a specific type of disease. So that's how the story began. So today I'm going to share with you what we've been doing in Brazil and sort of see how what we learn in the lab can be applied to understand what's going on in the field. So many of you are already probably familiar by now. This picture, right? This image. What is this? This is Ebola virus, right? So what if this epidemic that's taking place now, which is unprecedented in terms of scope, in terms of the number of deaths, number of cases, the duration of the epidemic, the number of countries affected. What if this epidemic occurred during the World Cup, okay, which happened in July this year in Brazil, right? What if this World Cup started in September when this epidemic exploded in West Africa? Okay, there are many. These are scenes from Sierra Leone. The urban settlements in Sierra Leone, over 90% of urban settlements in Sierra Leone considered to be slums. Okay, so what if some soccer fan went from Sierra Leone to Rio de Janeiro and then lived in one of the favelas called Rocinha during the World Cup event, and they developed fever, turned out to be Ebola, and it affects all these people in the favelas, so the slums of Rio. And all these people then, from all over the world came to the city, and then they go back to their countries. We may have really averted a true world pandemic. I think we're just very lucky that this epidemic didn't happen during the time of the World Cup. Okay, and so, and the reason this is happening now, that nobody talks about is the elephant in the room. People talk about poverty, people talk about poor access to healthcare, people talk about their cultural practices, people talk about the war that these countries had been involved in. Yes, those are all true. That's contributing to what's going on now. But what they don't talk about is that the reason this is happening now, and this reason is happening this scale, is because of the slums. Okay? Until now, until this epidemic, most of the transmissions had been taking in rural places where you didn't have this mass density of populations living in these conditions. Okay? So when this virus entered these slum settlements, this is what happens. And this is just one example of a disease where slum settlements can amplify these kind of highly transmissible infectious diseases. And nobody talks about this. And this is something that really illustrates just the total world's lack of attention to this issue. So many of you have seen this picture, right? So this is a picture in São Paulo, Brazil. And if you look at you see this fence here. It's just a simple little fence made of some cardboards and plywood. And if you look on this side of the fence, you see this tennis court with swimming pool. And this building, in each building has a little swimming pool in the veranda. Okay? Even by US standards, this would be considered a very, very wealthy community. But this whole community is separated by this little fence, and people live on this side. And there's hardly any sort of interaction that takes place across the fence. And if you look at this side of the fence, you'll see these diseases. You'll see these people who live in these places get diarrhea, acute respiratory infection, TB, AIDS, etc. And the people living on this side of the fence also will acquire these infectious diseases. But in addition, they'll acquire these diseases that people living on this side would never get, including advanced stage cervical carcinoma, which is actually a cancer caused by an infectious agent, okay, type of virus called HPV. And the reason for this is because the women living on this side of the fence don't get screened, okay, with pap smears. Whereas people on this side, of course, they can afford to do that, so they'll get seen, so they'll be prevented from their infection advancing to cervical carcinoma. And it's just a simple fence that divides these two communities. So about 11 years ago, the UN Human Settlements Program published this report called Challenge of Slums. And this is the first time some international organization recognized the existence of these human settlements in the world. And they actually use there is an operational definition. So slums are human settlements with inadequate access to safe water, inadequate access to sanitation and other infrastructure, poor structural quality of housing, overcrowding, and insecure residential status. So if you use this definition, then in the world, there are more than 1 billion people who live in these conditions. That's more than a third of the population. By now, this was 11 years ago, there's even more now. There's more than a third of the world's population live in these kind of settlements. And so they estimate that by 2030, 2 billion people will be living in these kind of settlements. And right now, 43% of the combined urban populations in all developing countries live in these conditions now. And then in the least developing countries, the reality of this kind of living situation is up to 80%. So these are the projects that we're doing in Brazil. We study diarrhea, leptospirosis. This is a disease that's transmitted, it's a type of bacteria that's transmitted by rat urine. So you have high density of rats, then you get this disease. Tuberculosis, of course, rheumatic heart disease. This is what I'm going to talk about. And then slum-specific disease burden assessment. So this is something that we're beginning to do anew in Brazil. So how many of you have been to Brazil? Okay, so you know Salvador, right? Salvador is up here. It's the third largest city in Brazil. It's really considered this sort of the spiritual capital of Brazil. It was the original capital of Brazil. And it looks like this, and it looks like this. And one of the places where we're working, we have our projects called Pau de Lima, which is a favela. Favela is a term, the Portuguese term for slum. So in the late 1950s, this is just an Atlantic rainforest region with no human settlements. And the area demarcated in yellow is where we're now currently doing our study. By mid-1970s, you begin to see these formal settlements outside of this region. And then by late 80s, you begin to see these informal settlements forming inside the yellow demarcated area. And then by early 2000s, just completely settled. So very rapid urbanization with the formation of these informal settlements. And so rheumatic heart disease, this is a immunologically mediated chronic complication of group A strep infection, meaning everyone in this room has had sore throat, right? And if it was a bacterial infection, it was probably caused by group A strep. Okay, these are the ones that your parents always worry about little kids having because in the old days, if you didn't treat it, it progressed to what's called the rheumatic heart disease, where it involves the heart valves. Okay, so my parents' generation, there are many people walking around with heart murmur, and they're probably due to this process, this disease. So what happens is this bacteria triggers an immune response, and the immune response recognizes the antigens on the bacteria, but also the heart valves contain similar proteins. So these immune responses then start attacking these proteins in the heart valves. And so it's just a simple sore throat like this, but then they can progress to having to replace the heart valves. Okay? And so it's very rare in the US now, but this is something that's actually quite common in many of the slums of the world. And why is that? And that's the question we try to address in Brazil. Okay? And so rheumatic heart disease results from repeated episodes of acute rheumatic fever or group A strep infections. And there's actually a changing epidemiology of this disease. So WHO used to say that the peak prevalence of disease is in young adults, and it used to be true in the US in the 1930s and 40s. But more recent studies from Brazil suggest that the mean prevalence of disease actually has gotten, the mean age of the prevalence of disease became much younger. So in one study, it was 12 years, in another study, it was 9 years. So that means that by the time you're in your early teens, these kids develop heart valves to a point where they have to be replaced. The valves have to be replaced with artificial valves. Okay? And because they're replaced so young in their age, they may have to be replaced again 20, 30 years later because the valves are artificial, they don't last that long. Okay? And it's a tremendous cost to the Brazilian government to have to replace these valves when they can be simply treated with penicillin or ampicillin, very simple antibiotics. Okay? So why do these kids develop this disease so early? So in Brazil, we're doing these projects. We're looking at first just assessing the prevalence of this disease and developing simple diagnostic tests, or prognostic tests. And then we're also trying to understand the risk factors for rheumatic heart disease. Is this because of the poor access to healthcare services? Or is there a difference in the circulating strains of group A strep? Or differences in other biological characteristics, such as the superantigens that these bacteria are known to make? Or differences in diversity of the strains. So these are what we do at the cellular level. And you'll see that there's already this disparity that occurs at the cellular level that translates into disparity at the social level. So what we do is we use this method called EMM typing, which is just, I'm not going to go into the details, but it's just basically genotyping or fingerprinting these bacteria, okay, by genetic methods. And so most common fingerprint types are these so-called EMM 1 and 12. These are what's most common around the world. And then, but there are many EM types, hundreds of these EM types. And in Pacific region and African countries, there appear to be greater diversity of these EM types compared to Western high-income countries. And so this is a report from Steer's group in Lancet that came a few years ago. So if you look, EMM1 and EMM12, you see they're the most common EMM types. And the ones in red are those that are included in the vaccine, this experimental vaccine formulation. Okay? So vaccine was developed with the Western countries in mind, right? So they're the one, they included these, the most common ones that are found in the Western countries, so they can give the vaccine so the kids don't develop the group A strep infection. But if you look at the African countries, yes, EMM12 is here, but EMM1 is down here. So the same vaccine, if it were developed, would be less efficacious in African countries. And if you look at Pacific countries, EMM is way down here, and EMM12 is not even there. So this vaccine would be totally useless if it were given in Pacific countries. Okay? And so we wanted to use the same genotyping or fingerprinting method to look at 3 clinics in Salvador, Brazil. And so this is San Marcos, which is one of the clinics that predominantly serve kids living in the favelas. And then Jorge Valente Clinic is a clinic that predominantly serves kids from families that have private insurance. And then Quinto Centro is another clinic that serves another favela near this clinic. So 2 favela clinics and 1 privately insured family clinic. And this is what we found. So if you look at what's called the Simpson's Diversity Index, you see this? And Jorge Valente, it was 0.92. Okay, this is the private insured family clinic. And then Quinto Centro and San Marcos clinics had much higher diversity. And if you look at the Steer's publication, you see this, the high-income countries was 92. Okay, so the diversity that we found in group A strep in Salvador, in this rich clinic, resembled the diversity you see in high-income countries. And then diversity that we see in these favela clinics resemble those that we see in Africa and Pacific countries. Same city, but these people, these kids, their diversity was similar to what we see in the US and Western Europe. Okay? And then the kids who live in the slums had similar diversity to those that we found in African and Pacific countries. So there's already this disparity here. Okay? So remember I just told you about this experimental vaccine. If this vaccine were to be given to the kids in Salvador, it's going to have differential effect. So in George Valente, you see that? 12 and 1, just like in the Western countries, the highest one. So in this clinic, this vaccine will work for the rich kids. Okay? But here, 12 is here, so okay, it might work in these kids, but 1 is down here. In Quinto Centro, 12 and 1 are down here. So the same vaccine will have less of an efficacy in the kids who live in the favelas. And so by understanding this sort of genetic basis, the genetics of these organisms, we can really predict how the vaccines are going to take effect. And we can talk about poverty and health disparity and social injustice and all of that, but it's already determined at the biological level, disparity. Okay? So you can correct all these, you can give access to these kids to clinics, but that wouldn't change until you change what's going on at the structural level in the favelas. Okay, so that's one example of what I call cell to the streets. Now let's go to Rio de Janeiro. So here we're interested in assessing disease burden in these communities. How do you quantitate how much of each type of disease occurs in these communities? And so as you know, in July of this year, Brazil hosted the World Cup, 32 countries in the world. But did you know that Brazil also hosted what's called the Street Child World Cup in April? Did you know about this? You didn't know this, see? It was never publicized. 19 countries from all around the world, street kids from 19 countries participated, okay, more than 200 kids. And so those of you who know about this, do you know which country won? So actually both boys and girls participated in this, okay? It's not just the boys. So I think I was, No, it was Tanzania. Won the boys, and the girls was, I think, Brazil. But anyways, and one of the countries that participated, one of the countries that sent the kids was from Liberia. Okay, so what if that Street Child World Cup was held during the time of the epidemic? Okay, the Liberian kid, developing fever. Once he gets to Rio de Janeiro, transmits the infection to other kids from all over the world. They go back home, they develop Ebola virus disease. Could easily have happened. I think we just avoided it by just a few months. So Brazil started these slum upgrading programs. I don't know if you heard. It's called PPC, where they're trying to do all kinds of things to upgrade the program. So one of the things we wanted to do was, just try to quantitate the burden of this disease before the upgrading programs and after the upgrading programs. So people can then really use the data to say which type of upgrading programs really worked or not. Okay, and so in this, what we do is what's called assess this disability-adjusted life years metrics. Do you know about DALYs, I guess, right? You know about this? So we wanted to calculate DALY gap. And so if you look at the most recent DALY report from all around the world that was done, that was published in Lancet a few years ago. If you look at, for instance, DALY per capita for tuberculosis in low and middle income countries, it's 0.007, okay? And if you look at the DALY per capita TB in high income countries such as the US, it's 0.0002. And so DALY per capita TB is 30 times greater in low and middle income countries. Okay, so you have these kind of data already, but what we don't have are the data from subpopulations in each nation. So that's what we wanted to do. So we asked the question, what is the DALY caused by TB in people who live in the slums and people who live outside of the slums? And then find the difference. And then if these slum upgrading programs are implemented, can they close this gap? So that's the sort of the rationale for our work. And so we wanted to do this project in one of the other slums here. It's called Complexo Alemão, or Peña, just northern part of Rio. And you can actually see sort of evolution of how slums. So during the Canudos War, which was in the 1800s, the federal government, Brazil, sent these troops to this one area in Bahia, the state of Bahia, to sort of remove these people who settled in these communities, led by this leader, the religious leader, sort of a fanatic leader. And the federal government failed 3 times to remove these people. And then for the fourth time, on the 4th try, they finally were able to just remove all these people. And the soldiers who participated in doing that, they went back to Rio, and they were all staying in this hill in Rio, waiting to get paid. And they never got paid. And they remembered the type of vegetations in the place where these people, the rebels were staying. And these vegetations were called favelas. They're a type of brush. It's called a tree brush. Okay? So this, the soldiers who were in Rio came to be known as the favelas. And then that came to be eventually known as the slums. And so that's how that's the story. But anyway, so the story of favelas, the slums, go back more than 100 years in Brazil. Initially, people would settle in just any open space, usually in the lowlands. Then as development took place in the 40s and 50s, these people were pushed up into the hills, so they moved into the hills. Okay? And then 1950s and 60s, the government started initiating programs and built these, in the US called projects, right? Project-type buildings. So what happened here? You know, that at least they made an attempt to resettle these people into these buildings that had electricity and water and all that. But what would happen if they did that? It was a total failure when they did that. Well, it disrupted the whole social network, okay? And that was very important. They need to preserve the social network, but when people are moved into these complexes like these, it just totally disrupts the social network. And so now what they're doing is to just try to do the upgrading in the very places where they live, okay? So they're building daycare centers and recreational facilities and education units, and actually the police now live in the communities. In this particular neighborhood, the police were placed in these buildings. So the police now live here, and the people live around here, okay? So you can see just, you know, these informal buildings just stretch, just go, you know, miles and miles away. So some of you know, so disability-adjusted life years is a sum of years of life living with a disability and years of life lost. And the years of life lost is calculated based on women in Japan, okay? You know the average age of women in Japan? They're the longest living humans on this planet, 88. Okay? So if you die before 88, that means you lost those number of potential years you could have lived. Okay? As a human being, you should be able to live at least to 88 years old anywhere in the world. So if you don't live until 88, you've actually lost those years, and that's how you calculate it. The number of years of living with disability, depending on the type of disease. You know, some diseases, like if you lose a limb, then you live the rest of your life being a cripple. And so those will weigh more than TB, which if you treat, after 1 year, you're cured. Okay? So TB contributes less to YLD. But if you're living in the slums, you may actually die early. You may die when you're small because you don't get treated right away. So TB will contribute more to YLL than YLD. But anyways, so if you look at the TB incidence, just the number of cases of TB per 100,000 per year, it actually went down from 2005 to 2010. Now, but you can see, even in 2010, it was 116 per 100,000, compared to US, which is 4 per 100,000. There's a huge difference. Okay? And so the world, the DALI for TB is about 49 million. In Brazil, it's 270,000, which translates to about 142 DALIs per 100,000. In Rio, when we did the analysis, it came to about 256 DALIs per 100,000. So Rio is much higher, almost more than almost as twice the national average. In Brazil, they use the term aglomerados subnormais to refer to slums, okay, favelas. There's a very specific Brazilian census definition of slums, and so when you use when you use their definition, then the DALIs per capita was 306. And then in the non-AGS, it was 236. So the DALI gap was 70. Okay, so we're able to calculate. This is what we wanted to do. And what's interesting is if you look at so the light purple represents the DALI gap. Okay, so if it's light purple, that means that the DALI was greater in the slum kids or slum people than in the non-slum people for TB. And this is for the male and the female. And if if you look closely, in some of these, even though the incidence went down from 2005 to 2010, the DALI gap actually went up. Okay, in some of the age groups. And then, but here, what do you see here? Here, in the light orange, the DALI for TB, DALI caused by TB in the non-favela people was actually greater in this particular age group, 20 to 39. Why do you think this is the case? This was very surprising to us, right? Just in this male young age group, this is what we see. We see actually a reversal of the DALI gap. What do you think? Why would the TB DALI be greater in people who live in the non-favelas? Because most of the young people in this age group are in jail. Okay? So they're not counted. Their address is not counted as being in the favela. So you can see how the tremendous impact of the slum on youth violence and crime, et cetera. And it actually affects diseases like TB, how we measure TB. So if you, again, look at the, so to compare, again, the AGSN versus non-AGSN. Non-AGSNs are the oranges, and the AGSNs, the slums, are the purple. And you can see this is the mean monthly income versus the census tract population density. You can see in the slums, they all, the TB, all DALIs, all cluster in the low-income groups. There are not that many people that go beyond this 1,000 US dollars per month. But among the, even among the non-AGSN, they sort of scatter all across the different income groups. And sort of contrary to what we thought, larger number of cases cluster in the low density households compared to the higher density households. And so, so TB is not limited just to AGSN or the slum populations in Brazil. And the TB DALI gap between the highest and lowest income group was 323. Okay. And these are the maps that were done. These are all done by a postdoctoral fellow, Marielle Marlowe, from here. And she's living in Rio to do all this project. And so I don't know if you know Rio. This is sort of the south zone where all the tourists go. So this is Copacabana, and this is Ipanema. And all the purple ones, are the favela census tracts, and the brown orange ones are the non-favela census tracts. And these are the sort of heat map. So the darker the purple, the greater the DALI. And there's an area called Rocinha, which is here. And I think some of you have been to Rocinha, which is the largest favela in the Americas. Okay? And you can see there's a purple area. We're actually curious to why this particular area had much higher DALIs than the other parts of Rocinha. You can see. So we walked through there, and this is what it looks like, just walking through the streets. And then we found this clinic. So it's a TB clinic. And we think that the reason there's so many cases reported from that particular is because of the TB clinic. Either the clinic reports these cases that are found, or that people who live in this neighborhood are more likely to go to the clinic for the diagnosis to be made, right? And so there are more cases that are reported. We don't know for sure, but it was interesting. It was, that we would not have found this if we were only just working in front of a computer and just doing the analysis. The point of this study is that you can't just do the analysis, with the data that you get here in a nice, cool atmosphere of Berkeley. You have to actually go into the street and look to see what your data is telling you, and they can understand better what's really going on. And then you can make the right interventions. So we already have several bits of information that we can now use to make specific, very focused interventions. There are interventions you can make for TB, to prevent TB in these populations. So let me just end by showing this video. If it works. So it's only about 2 minutes. So. How many of you have seen this? No? Okay, good.
Mi nombre es Ríos Bogado, tengo 13 años y Me llamo Juan Manuel Chávez, más conocido como Eddie. Tengo 19 años y toco el cello. Este cello está hecho de una lata de aceite, la madera tirada en la basura y las clavijas son de una vieja cuchara para golpear la carne y para hacer el ñoquis. Y suena así.
Un lugar para tener un violín. De hecho, un violín cuesta más que su casa.
Nesse grupo acá mismo tocamos con la de violín. Y ese empezamos los instrumentos reciclados.
La familia que acá vive recicla todo lo que hay en la basura y se vende. No pensaba antes que yo voy a hacer esa instrumento. Y me siento demasiado feliz cuando estoy viendo a un niño que está tocando un violín reciclado.
Cuando ya escucho el sonido del violín siento como mariposas en el estómago, así una sensación, no sé cómo voy a explicar.
La orquesta de instrumentos reciclados es una orquesta que toca instrumentos hechos con la basura.
1, 2, 3.
Mi vida sería, sin la música, sería descubrir.
La gente se da cuenta que no tenemos que tirar la basura muy fácilmente. No tenemos que desechar a las personas muy fácilmente.
So, you know, we always talk about poverty and disparity and inequality, all these things, you know, sun comes up every morning, you know. So it's kind of boring. I think we can't wait for social capital development, technology transfer, UN Millennium Goals. We have to really act now to formally recognize the existence of this population and assess burden of disease in this population, develop new metrics, and then conduct research and report findings in international journals and provide data for national governments, identify and implement novel interventions specifically designed for slums, and then finally get those in position of influence to set the priorities straight. And so somebody said this recently, you know. He said, the main stock exchange go up or down 3 percentage points, and this is a world event. And this kind of it's time to flip the tortilla. Who said this? Okay, I have never, you know, quoted a pope in my talks, but you know, I think this guy is, you know, has a right head. And so I'll end it here. So these are the people who've actually participated in many of these projects, and my collaborators, and etc. Okay, so I'll be happy to answer questions. Huh?
I'm not personally responsible for the reintroduction of cholera in the Western Hemisphere, but I happened to already be in Peru when it happened.
Mm-hmm.
And there was a pretty quick public health response, but it was most of it was centered on the slogan, wash your hands.
Yeah, sure.
And of course, people in the slums have to buy their water from trucks.
Right, right.
Sometimes go there. So it just seemed impossible.
Mm-hmm, right.
So how do you do an immediate response when the key thing is infrastructure?
Right. So, you know, it's a good question. You know, what do you do with the Ebola, you know, epidemic, right? They're having so much difficulty controlling, right? And I think it's because of these conditions that you also saw in Peru. So the way we approach it, you know, we're researchers. I'm an academic person. I do research. You know, I don't know how to do interventions, but we can at least provide the data that they can use now to do something. So like this TB situation, we know which subpopulations and which even neighborhoods, in Rio have the highest daily gap, right? And so maybe efforts could be made to target these subpopulations in specific places in the city. Something like Ebola, if we understand who are at risk for transmission, what sort of conditions facilitate the transmission. For instance, Nigeria, the country next door, they've been very successful in really preventing the epidemic, right? And they have, in Lagos, it's a huge slum community, and yet, for some reason, they haven't had this problem. Why is that? So if we understand the difference, what is it about these slum communities that causes these epidemics to flare in one place and not in the other? If we understand those differences, then I think we can make interventions right now instead of waiting, for the governments to improve the infrastructure. I don't think those approaches work. I don't think anybody knows what to do with these slums. Brazil has had the longest experience in dealing with this issue than any other country, and so they're doing this new experiment now. We don't know if this is going to work or not, but those are long-term solutions. I think what we need now, people are dying right now, and we need to identify what we can do now to prevent at least the deaths that are occurring now, or at least interrupt the transmission that's going on right now in West Africa for Ebola. Okay, and it takes research to do that. And so, but I really don't. A lot of the work that I do, I work with Jason Corburn here, who is a faculty member in city and regional planning. So he does more of the kind of the advocacy work, intervention work. And he works in Nigeria, and he's also helping us with our work in Brazil. So he's you might want to invite him to sort of talk, because he sort of looks at it from more of the implementation science point of view, whereas we sort of do more of the research to generate the data that other people can use to kind of devise interventions. So. Okay, yeah, you have a question?
Yeah, I lived in Rocinha for a few years, and there's that street where the government tore down a lot of the houses to widen it and reduce density. And people's perception of that I usually heard is that they've done it to reduce TB, but people weren't really sure if it worked or if the government was just saying that because they wanted to tear some stuff down. So do you know, is the real problem in the slums with spreading TB the density, or is it more about sanitation?
Well, it's probably just a lot of factors. Yeah, I don't think tearing down buildings is going to have any impact on TB. As you saw, and it wasn't really associated with density, right? In fact, it's a lower number of people per household that those had a higher transmission. So it's really there's a lot of biology here that we don't understand, and for some reason, so the TB is an infectious disease where once you're infected, it can be infected for a long time. And the problem, so 1/3 of the world's population is actually infected with this bacteria, okay? The problem is we don't know when, who, and where these people reactivate the disease. And it becomes transmissible only when you reactivate the disease. And you can reactivate the disease, a few months after an infection or many years after an infection. Okay? And so there's certain types of conditions that, of course, cause the reactivation, such as diabetes or, getting HIV infection, okay? Or even just stresses. And maybe we definitely have, data showing that the lowest income people have the highest TB DALYs. And so maybe the stress of poverty induces the reactivation. So perhaps, and there are ways to actually prevent the reactivation. That's what we do in the US. That's why TB incidence is so low in the US. When somebody's skin test is positive, it's documented to be newly positive, you give a treatment for 9 months, okay? And so, so there is a modality to prevent reactivation disease. So if we can identify those people at risk for progression to disease, then we can probably make a difference. That's the real solution, not tearing down buildings and changing the infrastructure, because I don't think they work. Another thing I didn't show you was, so we also mapped these census tracts according to the amount of different types of infrastructure services that are available to, such as collection of garbage, provision of electricity, provision of safe water. Most of the favelas, even in the favelas, they actually have more than 90% safe water coverage. But there are some differences in terms of the electricity coverage. So the ones that had lower than 60% electricity coverage, they had the highest DALY for TB. We don't know why, what the relationship between electricity coverage and TB is. But maybe, again, it's a marker for poverty. I don't know. But those are the kind of things that we can actually begin to see and understand what contributes to the reactivation disease. But all these things are disease specific, right? So I happen to study TB, so we know what to do. In Bahia, in Salvador, Bahia, we were studying leptospirosis, which I mentioned earlier is a disease that's transmitted by rat urine. So you can remove the rat density, but that's impossible. Even in the U.S., there are more rats than human beings, in the U.S. So that's just not going to work. But what we do know is that if you close, we've identified several risk factors. One is living in close proximity to open sewers. Okay, that was a huge risk factor. Because what happens in these favelas, they get flooded during the rainy season. People have to walk through the flood. And this bacteria, it's a type of spirochete bacteria, will actually bore through the skin and then rapidly enter the bloodstream, disseminate all over your body, and it shuts down your kidneys and your liver, and you die very quickly. Okay? You can tell them to wear, long boots to avoid the water. That's not possible. But what they are doing and what they have done is to close a lot of these open sewers. And again, that's an intervention. And what's interesting about that is by providing piped water and closing the sewers, it not only reduced the incidence of leptospirosis, but also reduced all the other diseases associated with bad water, such as diarrheal disease and then skin infections. I don't know if you know, but lack of clean water can contribute to scabies and all these other skin diseases. So those diseases also decreasing. Okay, and so again, just having that information and having this very focused intervention can make a difference. And we can't wait for people to get rich and all those things. That's just not going to happen.
So are you saying that slogans, just to go back to your comment about the, wash your hands, you're saying that it needs to go beyond just the slogans and beyond just waiting for people's situations to get better, but actually have very specific interventions targeted that might maybe target multiple diseases? Right.
Yeah, you could do that too. So in the case of leptospirosis, one intervention had an impact on many other diseases, including leptospirosis. Maybe you could do that with TB. And so we don't know. See, we can't predict ahead of time what impact those things are going to have. So that's why we focus on one disease at a time and then try to see what happens. And I've been talking mostly about infectious diseases, but there are many other non-infectious, non-communicable diseases that occur in these communities that we have no understanding about. Okay, like diabetes, hypertension. We just completed a study on hypertension and it's actually interesting. It's actually because the average age of these communities is much younger than the sort of general population. Hypertension prevalence is actually lower than the general population. The difference is that even though it's lower, most of those people with hypertension are not on any medication. They don't even know that they have hypertension. Because, if you have hypertension, do you know that you have hypertension? You wouldn't know unless you have a stroke, you get a stroke, or, a heart attack, or, you get a kidney damage. So you would not go and seek any medical assistance until you develop these complications. And by that time, it's too late. And so these people who have hypertension now, but they don't know, need to be on treatment. So that's the difference. Even though the overall prevalence is lower than the general community, there are interventions that need to be made to prevent these bad consequences later. So those are, the kind of things we're doing. So we have, many students here from our MPH program, School of Health, who go and, participate in these projects. And we actually have a training grant from Fogarty International Center called a Global Health Equity Program, Scholars Program, where we fund fellows and students to spend anywhere from 8 months to 11 months abroad to work on these projects. It's a consortium of 4 universities. Berkeley is the lead institution. We have Stanford, Yale, and Florida International University. So if you guys are potentially interested in doing something like that, just contact. For those of you students, postdocs interested, you can contact us. And, you can do these things. So. Okay.
Who are your partners in Brazil? Because I imagine you have to have strong partnerships there to make these interventions and to appreciate the data that you're creating.
Right. So, I've been working in Brazil for more than 20 years, and many of the projects started because of the training grants that I've had here, where I bring Brazilians to come to my lab and they work. And then when they go back and they gain positions, at their institutions, they become collaborators. And so in Bahia, we have most of the collaboration has been with this research institute called Oswaldo Cruz Foundation. There's a branch, the main headquarters in Rio, but there's a branch in Salvador. And the director of this institute, Mitamaya Galvão Reis, is someone who is very active, politically, and kind of played a major role in helping us kind of launch these projects. And the reason I think he did that is because when he was a medical student, he actually lived in the favela where we're doing a project. He's from a very poor family himself, a lot of brothers and sisters, and his father passed away, and that's why his name is Mittermeier, which is a German name. This German doctor treated his father, who passed away. But anyways, so he was very instrumental in kind of facilitating it. We continue to collaborate. And, a lot of the leptospirosis work was done by my former infectious disease fellow, Albert Koch, who's an American, who went down to Brazil and stayed there for 15 years. Raised his family there pretty much, and then worked in the favelas for all these years. In Rio, again, it was through collaboration that I've had here on TV, and then, so it's a lot of this is just all personal connections. And if they're, these connections happen to be active with either the local government or the central government, then it makes our life a lot easier to get things done. And so, and Brazil is actually a very what should I say, rewarding place to work, because it's a very wealthy nation, and for the last few years after the military government was removed, I think they actually listen to you. They actually take your data that you generate seriously and do something with it. And they're wealthy enough to actually do something with the data that you have. So the leptospirosis work that we're doing in Bahia, they actually offer to put in the piped water system and close the sewage. In many other countries, even if they're well-meaning, they can't afford to do it. And so it's very frustrating for the researchers, because even if you provide the data, nothing gets done. Whereas in Brazil, they actually do things. They actually wanted us to set up a similar surveillance system for leptospirosis in other cities, in Brazil, after we came out with our first report. And so, they're much more responsive to the data. Mm-hmm.
That genetic disparity in the strep, well, it wouldn't be in response to the vaccine itself. Was it just random? Yeah, the vaccine is an experimental vaccine, so it has not been, administered anywhere yet. So that's why they have these data. They're collecting these data about diversity, so they can see where, it would be most useful. So no, this is just, we don't know why there's such a high diversity. Maybe, again, it's because of the high density, population living. So group A strep, they have a tendency to horizontally exchange their DNA materials. And so, in a very high density environment, maybe there's more opportunity for these bacteria to exchange their genetic materials, so they become more diverse. Now, how that contributes to rheumatic heart disease, we don't really know. So those are some things that, I like to study more, but we can't do everything. So, maybe hopefully somebody else will carry on that work.
I think we're just about out of time, but thank you so much.
Sure. It was a real pleasure. Okay, thank you.